Bună ziua tuturor! Bine ați venit la webinarul Stimularea Electrică Transcraniană tdcs prin HDC Stim pe abordare terapeutică inovatoare. Eu sunt Mirela Prăsecan, sunt în acest domeniu de peste 5 ani împreună cu Neuronica. Mie îmi revine rolul astăzi de a vă oferi toate informațiile legate de acest webinar, de a vă prezenta cei doi oaspeți, cei doi speakeri pe care îi avem, de a le pune întrebările voastre, de a vă da toate comunicările și sigur că dacă merge bine, totul va fi meritul meu. Nu, glumesc. Va fi meritul lor, va fi meritul organizatorilor și, evident, dacă nu merge bine, ne treceți cu vederea și îmi asum vina. Glumim. Trecem la lucruri serioase. Mulțumirile mele se adresează în primul rând organizatorului acestui webinar, domnul Ovidiu Săcuiu, care este manager al clinicii Medanima din Iași și Medanima Tech, care a ideat și a făcut posibil acest webinar, colaboratoarei lui Ramona Oprișan, care nu se vede, care e în spate și care a fost cu tot entuziasmul și trup și suflet ca totul să fie gata la timp și să iasă bine. Desigur, celor doi speakeri, profesor Roberta Ferrucci și profesor Giordano D'Urso, pe care îi voi prezenta imediat. Mulțumiri dumneavoastră, desigur, pentru interesul și participarea de a fi astăzi cu noi. Mulțumim de asemenea și traducătorului nostru, vom avea traducere simultană. Vă voi spune imediat și vă voi da imediat toate informațiile tehnice referitoare la aceasta. Este primul webinar de acest gen din România, din câte știu, și sigur că după perioada dificilă prin care am trecut cu toții, ne-am obișnuit cumva cu acest format online, dar știm că față în față e mult mai interesant, e mult mai bine, așa încât încercăm și ne-am făcut promisiunea nouă și vă adresăm și noastră invitația ca în viitor să facem sesiune live, poate la București, poate la Iași, poate în altă zonă a țării sau poate undeva de unde vom avea cele mai multe solicitări, așa că nu ezitați să-i scrieți lui Ovidiu pentru aceasta. Bun. Ne bucurăm să vă avem deci alături la acest webinar dedicat exclusiv specialiștilor din sănătate pentru a aborda tematica de astăzi, tematica care este despre o tehnică simplă, neinvazivă de stimulare a creierului, care induce modificări funcționale pe termen lung în cortexul cerebral, așa cum profesorul Alberto Priori a vorbit deja în 1998 și în 2003. Bun. O să vă dau niște informații tehnice de organizare. Vă spuneam că există o traducere în timp real din engleză în română și aveți opțiunea ca participanți de a asculta varianta tradusă cu un reglaj de volum. Puteți asculta atât vorbitorul cât și traducătorul în același timp 50-50 sau 20-80 și aici vă dau mai multe detalii. În situația în care vorbitorul intervine în limba română, puteți să dați opțiunea off în meniul butonului de traducere și astfel veți asculta intervenția în limba română. Dacă vorbitorul intervine în engleză și considerați că puteți înțelege ceea ce spune fără a avea nevoie de traducere, dați click pe opțiunea off a meniului butonului de traducere și astfel puteți asculta versiunea în engleză. Iar situația 3, dacă vorbitorul intervine în engleză și doriți să ascultați traducerea în limba română, puteți da click pe opțiunea Romanian la meniul butonului de traducere și astfel ascultați traducerea, versiunea în limba română. Sper că e clar totul, dacă nu vă rog să ne scrieți pe chat și vă vom da ulterior informații. Bun, și acum vă spun și structura webinarului. Da? Deci vă spun că, așa cum puteți vedea, webinarul este înregistrat pentru documentare ulterioară. Puteți cere pe mailul osăcuiu@medanima.ro, puteți să-i cereți domnului Ovidiu Săcuiu înregistrarea și o veți primi pe mail, da? Fiecare dintre noastre care doriți această înregistrare. Vom avea, după sesiunea cu cei doi speakeri, profesor Roberta Ferrucci și profesor Giordano D'Urso, care vor avea fiecare câte o intervenție de aproximativ 30 de minute, 30-40 de minute, în funcție de prezentările pe care le vor face. Vom avea o sesiune de question and answer, da? Întrebări și răspunsuri. Aveți un meniu întrebări și răspunsuri, da? În josul ecranului, unde puteți scrie întrebările dumneavoastră. Dacă le adresați general celor doi speaker, scrieți direct întrebarea. Dacă aveți întrebare pentru unul dintre ei, o să vă rog să scrieți căruia îi adresați întrebarea noastră. Întrebările specifice întrebărilor specifice le va fi răspuns în scris, e-mail, și sigur că vom avea posibilitatea și să facem o întâlnire 1 la 1, unde doriți să aveți mai multe informații, mai multe detalii. Iar pentru toate informațiile legate de particularități de sistem în România și de tot ce presupune aceasta, domnul Ovidiu Săcuiu vă stă la dispoziție, o să vă dăm din nou mail-ul dânsului, probabil aveți, și cu tot ce ține de partea aceasta, el e bucuros să vă stea la dispoziție și să vă ajute în direcția asta. La sfârșit, vă mai spun că vom avea un feedback chestionar, deci vă vom ruga să completați un chestionar care ne va ajuta și pe noi și pe noastră în procesul de informare a tot ce înseamnă tdcs, a tot ce înseamnă stimulare electrică transcraniană și sigur că informațiile pe care putem ulterior să vi le dăm sau ajutorul pe care putem să vi-l dăm în acest sens. Bun, trecem la cei doi invitați, cei doi speaker de astăzi. Îi avem pe profesor Roberta Ferrucci, care este profesor asociat de psihobiologie și psihologie fiziologică, director al Departamentului de Psihologie la Universitatea de Studii din Milano, Italia, la Centrul de Cercetare Aldo Ravelli și Santi Paolo e Carlo, Polul Universitar San Paolo din Milano. În primul rând o să o invit pe Roberta să vorbească, după care îi vom da cuvântul profesorului Giordano D'Urso, și el medic psihiatru, specialist în psihoterapie cognitiv-comportamentală, profesor al școlii de specializare în psihiatrie a Universității Federico II din Napoli, Italia, și profesor al școlii de psihoterapie cognitivă din Napoli. O să începem cu Roberta. Roberta, dincolo de toată titulatura pe care v-am spus-o mai devreme, are foarte mulți ani de experiență cu utilizarea tdcs, este printre primii din Italia în utilizarea tdcs alături de profesorul Alberto Priori. Are o experiență foarte vastă, are foarte multe publicații în revistele de specialitate, nu doar pe direcțiile certificate pentru folosirea HDC Stim în terapia, în tratamentul și, sigur, dispozitivul medical HDC Stim, deci TDCS, ci și pe foarte multe alte direcții off-label despre care vă va vorbi direct. Așa încât, Roberta, thank you for being with us today. Thank you for your availability to be here with us today. Can you hear us? You need to, you have the microphone off?
Yes.
Okay, perfect. Hello, Roberta. Thank you.
Hello, how are you? Fine, thank you.
We are all fine. We are happy that you are here with us. Thank you for your availability. Thank you for all the information that you will share with us today, for your expertise in this field, in TDCS, and with use of HDC Stim. Are you ready to share with us all your experience? And
yes, thank you.
For
My
everything.
presentation is an introduction of the technique, and Professor Giordano D'Urso speak about the clinical aspect of his technique. Okay.
That's perfect. So let's listen, Roberta. If all the persons, all the attenders have activated the translation, maybe we can start. Okay, let's start. Thank you, Roberta.
Thank you.
Alteration of neuroplasticity and cortical excitability are important pathophysiological factors in many neuropsychiatric and neurological diseases. Now, to modify cortical activity by using non-invasive brain stimulation may be a valuable therapeutic approach. One of these approaches is in demonstrating rats that neural activity and cortical excitability could be modified by the application of current stimulation. These effects, depending on the stimulation polarity and the first 4 hours after stimulation. A few years later, it was established that the current century logical function effect via transcranial application of such like current subject and patient suffering from psychiatric disease. However, mainly due to the lack of relevant to effective heterogeneous effect, this technique to forget and we here. The physiological effects started to be systematically explored. is TDCS? Transcranial direct current stimulation is a non-invasive brain modulation technique that uses constant electrical current for stimulation or inhibition of a specific brain area. A low-intensity direct current passes through two electrodes, anode or cathode, placed over the scalp in specific position, modulating neural activity. TDCS occurs via constant electric current produced by a battery-operated current generator connected to at least two electrodes applied to specific head location or extracephalic region in the case of the return electrode. Most of the electric current is shunted through the scalp, skull, and cerebrospinal fluid, but the remainder alters neural resting membrane potential, increasing the likelihood of depolarization or hyperpolarization without inducing action potential. Polarization directionally depends on the axonal dendritic orientation with the electric field. The primary effect of TDCS of neuron is a subthreshold shift or resting membrane potential towards depolarization or hyperpolarization, depending on current flow direction relative to axonal orientation. Delivered to the motor cortex of the subject, another TDCS increases the excitability of the underlying cortex, as revealed by an increase in the amplitude of the motor evoked potential to transcranial magnetic stimulation, whereas cathodal TDCS decreased stimulation of short duration, several seconds, is sufficient to induce this excitability change, which, however, does not relevantly outlast the stimulation period. A longer stimulation duration, several minutes, induced excitability change that can last for 1 hour or more. Since TDCS modulates resting membrane potential at the synaptic level, but more generally along the wall axons, this may result in non-synaptic effect, which may also contribute to the long-lasting effect of TDCS. This non-synaptic mechanism of TDCS may be based on change on conformation and function of various axonal molecules involved in the transmembrane conductance, membrane structures, cytoskeleton, or axonal transport when exposed to a DC field. Another important consideration in understanding TDCS effects is that almost all tissue and cells are sensitive to electric field, and therefore TDCS may also elicit change in non-neuronal tissue in the brain, including endothelial cell, lymphocyte, or glial cell. These non-neural effects, which have not been systematically explored to date, could also be involved in the therapeutic action of TDCS. In patients with cerebral disease, designed neuronal damage, other important pathological processes may exist in the axonal microenvironment, such as inflammation. Behind the neuroinflammatory diseases such as multiple sclerosis, inflammation in the central nervous system has been implicated in several neuropsychiatric conditions, such as in the progression of neurodegeneration in Alzheimer's disease. Hence, through its possible influence on the inflammatory response, TDCS might theoretically impact on the course of the disease. Also relevant in Alzheimer's disease, one should note that the conformation of beta-amyloid and other pathological proteins can be changed when exposed to appropriate electric field, possibly modifying their susceptibility to degradation. In addition, this field can enhance axonal regeneration and neurated outgrowth, and therefore hypothetically improve functional recovery. TDCS may be able to influence several pathological processes and pathogenic cascade in the central nervous system, while behind the sole change of neural excitability. The clinical change provided by TDCS may strongly vary according to many technical and anatomical considerations and relationships. It is crucial to take into account the human little variation of electrocyte area, shape, or placement, such as different montage, can strongly influence the diffusion of the current and the geometry of the induced DC field into the brain. All of these factors could explain the variable results provided by TDCS trial in pathological condition. They should be taken into account for design and stimulation protocol and interpreting the effect of TDCS when applied in patients with a neuropsychiatric disease. TDCS is a safe technique. Typical side effects are transient and minor. For example, skin irritation, erythema, itching, or tingling. One of the main advantages of the TDCS is the sham-controlled clinical study. The subject feels the same initial sensation during active or during sham TDCS, because TDCS induces initial itching sensation lasting about 10 seconds. And for the sham, electrode is replaced as for real TDCS, but the current is turned off after 10 seconds. Because of the wide diffusion of TDCS or TDCS-like machines that can be bought freely on the internet, it will be difficult to restrict the use of this machine and ensure correct application. He also refers to the topic of neuroenhancement as it relates to improving the capacities of a normal subject and not to treat pathological conditions. In this context of free access to technology, neuroenhancement by TDCS is the subject of many ethical and regulatory debates and scientific controversies. In fact, theoretically, TDCS may have the capacity to enhance attention, learning, endurance, motor execution, memory, or other higher order processes, such as the decision-making, risk-taking, or problem-solving. Therefore, there is a need for maintaining a level of technical scientific excellence and considering regulatory issues to not discredit this therapeutic perspective. Research currently develops to explore the possibility of using the transcutaneous disease stimulation on other neural targets, such as cerebral and spinal cord, in order to promote functional and neural change. These two techniques are used especially for psychiatric disease and for pain disease. We have evidence-based guideline for the use of transcranial direct current stimulation in neurological and psychiatric disease. In the randomized clinical trial, TDCS showed effectivity in the treatment of various conditions, such as depression, neuropathic pain, migraine, fibromyalgia, stroke, Parkinson's disease, and more other neurological diseases. In conclusion, TDCS is a promising technique as a therapeutic tool in neurology, psychiatry, and pain. It is cheap, safe, portable, and can be applied to a large number of patients. TDCS has to be considered as a complementary approach to drug therapy, being able to enhance the effect of pharmacological treatment.
Thank you, Roberta. Thank you for this introduction in TDCS. I will introduce Professor Giordano D'Urso. As I told you, medic, o să vorbesc în română acum. Giordano, I will present you in Romanian. Medic psihiatru, cum vă spuneam, specialist în psihoterapie cognitiv-comportamentală, profesor al școlii de specializare în psihiatrie a Universității Federico II din Napoli și profesor al școlii de psihoterapie cognitivă din Napoli. Professor Giordano D'Urso has a very specific use of TDCS, of HDC Stim, in different areas, a lot of publication in all the publications, specific publication. So with many years of expertise, both in clinical and scientific use, will give you a more detailed approach of this technique and this treatment and this specific medical device. So Giordano, thank you for being with us today. Thank you for sharing with us your expertise. We are really glad to have you here. So please.
Thank you, Mirella. Thank you, Neuronica, for inviting me. And thank you all 108 participants for being here with us. So I'll going to share my screen. You can see?
Yes, we can see your screen, yes.
Okay. So I'm going to speak about the use of transcranial direct current stimulation in psychiatry. I had to make a choice, and I will speak about this because there are many conditions in psychiatry and neurology where tdcs can be useful. To start, I'd like to say that now we are at a paradigm shift in psychiatry, because we are shifting from a paradigm where brain was considered as a soup of neurotransmitters and drugs. That means that when a person was depressed, we used to put in the soup some serotonin and then taste again the soup, and if it was still bad, we put in some dopamine and so on. So not a specific and very scientific way to face the problem. Now we're going to another different perspective in which mental function are correlated to specific neural networks that can be selectively modulated for therapeutical purposes. And this is the word of brain stimulation. These are some of the brain stimulation techniques that can be used for therapeutical purposes. As you see, there are many of them, and each of them can have his specific collocation in therapy. But what is the potential of brain stimulation in psychiatry? Why is brain stimulation so important? Because thanks to brain stimulation, we can go from correlations. That means that what we have done so far is to correlate, for example, a neuroimaging feature to a clinical picture. We can shift from correlation to causation, because we can verify our hypothesis. For example, if in depression we have an hypofunction of a structure of a cortical area, using neuroimaging, we can only have a correlation between these two phenomena. But with brain stimulation, we can verify this hypothesis by stimulating that specific area. And if this causes improvement in symptom, I can say that that is the cause of depression. So the brain stimulation is going to draw new models for psychiatric disorders. And this is not the most important thing, but the most important thing is that these new models can lead to new treatment that are based on the neuroanatomy of that specific patient, so that are highly customized. This is the landscape of brain stimulation and neuromodulation techniques that can be used in psychiatry. As you can see, from the least invasive to the most invasive ones. Today we are talking about transcranial direct current stimulation that has very specific features that make it very useful in psychiatry. Let's see what. So these are the clinical applications of tdcs that are now researched for the use in therapy. Of course, you can see there are neurological and psychiatric conditions, and the ones that you see underlined in red are the ones that I usually treat with transcranial direct current stimulation. As you can see, there are many conditions, and of course, in some of them, the evidence is more solid. In some others, we need still more data to state if the TDCS is efficacious or not. Anyway, for this presentation, for the conference of today, I had to make a choice, as I was saying before, because of time, and so I chose to speak about especially depression, and I will also make a little focus on schizophrenia. This is because depression is the most from an epidemiological point of view, is the most important condition, and also it is the condition where there are more studies done so far. Schizophrenia is also a very important condition in psychiatry, and also these are the two conditions, the two indications in which there is a more robust evidence of efficacy. This is the, Roberta already showed this paper, which is the most recent review, systematic review about the use of transcranial direct current stimulation in therapy. And as you can see, for what concerns psychiatry, the most important results refer to major depressive disorder, where TDCS in the anodal version of left dorsolateral prefrontal cortex is considered definitely effective for treatment of depression, with the highest level of evidence, level A. In schizophrenia, and particularly in auditory hallucinations and positive negative symptoms, TDCS is considered probably effective. So the second level of evidence, level B, an average level. So let's see something about depression. The rationale for using TDCS in depression is that we know from neuroimaging studies that there is a prefrontal asymmetry between the two frontal lobes, with the relative hypoactivity over the left and relative hyperactivity over the right. So the idea, the original idea was to stimulate the left side of the frontal brain and to inhibit the right side to restore this the balance, the physiological balance between the two hemispheres. Another rationale is related to another imbalance that there is between an hypoactive cortical, so superior or dorsal cortex, and a hyperactive subcortical areas. With the TDCS, we stimulate the cortical, so the upper brain, and this stimulation can in turn inhibit the subcortical areas through the inhibitory connection that from the cortex goes down into the deep brain. 3, we know from TMS study that a stimulation of the left dorsolateral prefrontal cortex is effective in reducing depression symptoms, and the converse is real for the right dorsolateral prefrontal cortex. So the idea was to try to replicate those previous studies about TMS. But where to put the electrodes for treating the depression is still an open question, because it is quite clear that to stimulate with an anodal electrode, the left dorsolateral prefrontal cortex is effective in treating depression. But what should be the perfect shape? What should be the perfect dimension of this electrode is not so clear. And where should we put the other electrode on the right hemisphere, right frontal hemisphere? Where exactly? as you can see, there are many possibilities, and all these that you can see now, that you can see here, are montage that have been used in depression studies. And this is important because, as Roberta said, the shape and the position of electrodes on the scalp modify the direction of electricity, so can alter the clinical effect. Not only the position, but also the direction of the electrodes on the scalp can be an issue, can make the difference. Okay, so this is a first, let's say, issue when using TDCS, something to still know about it. But we know from this review, from this systematic review, that TDCS is effective in treating depression. And this particular systematic review published on a very important paper, a very important journal, selected 15 randomized controlled trials involving both active and sham TDCS. So the difference you see are real difference and are difference control versus placebo, versus sham stimulation. So this is the final forest plot about the efficacy of TDCS, and as you see, the result is in favor of TDCS. So what we saw is that the analysis of this sham control RCT showed a significant effect size, still a little effect size, but significant, in favor of TDCS. And the heterogeneity of these studies was quite significant because of those different methodologies. This is another less recent review article about TDCS in depression, but in this paper we find a more in-depth discussion of results. So I would like to show what they found. They found that TDCS is superior to placebo in terms of depression improvement, clinical response, and remission for an acute depressive episode, and that we already know. But what is interesting is that TDCS presents similar efficacy to antidepressant drugs and RTMS. Treatment-resistant depression and higher TDCS dosage were negatively and positively, respectively, associated with treatment response. That means that patients with treatment-resistant depression respond worst to TDCS, while higher TDCS dosage are often useful to get more important results. There are many other features of patients that can be important and can be modified in response to DCS. For example, if the depressive episode is in the context of a bipolar disorder, the severity of depression, and also the gender and the use of drugs. So the presence of bipolar disorder is not considered a problem. There are studies that instead say that bipolar depression responds better than unipolar depression, but this is not sure for the moment. Of course, more severe and drug-resistant depression respond worst, and the augmentation with serotonergic agents is considered to be useful with TDCS. Some say that male gender respond better, but this is not sure for the moment. This is another forest plot, still positive for the efficacy of TDCS. And the conclusion of this review are that TDCS is effective in major depressive episodes, is a safe alternative to antidepressants, is not supported so far in treatment-resistant depression, as it not supported as an add-on treatment of patients already undergoing drug treatment or cognitive control training, because in these patients, it seems that it doesn't bring a further effect. But this is still a matter of study. Okay, now, since we have seen that the effect is real but is small, we have to ask ourselves why this is. Probably because not all patients respond the same way. So if there is a heterogeneity in response, maybe that some patients don't respond and other respond very good, so very well. So we need to search for response predictors to select in advance which patients will respond to TDCS. And this is the research question that with Roberta and other Italian researchers tried to respond with a study of some years ago, where our objective was to analyze the pool data from all depressed patients recruited that far in Italian TDCS studies in order to identify potential clinical predictors of response. What we found in these 171 patients with the major depressive episode in the context of a unipolar or bipolar mood disorder, what we found was that there were clinical aspects that predicted a good response to TDCS. In particular, there was no difference depending by the center. There was 3 centers in 3 cities of Italy. No influence of age, no influence of sex, no influence of diagnosis, bipolar or unipolar. But what mattered was some specific factors of the Hamilton Depression Rating Scale. So maybe, as you know, the total score of the Hamilton Depression Rating Scale can be divided in subscores that correspond to specific clinical aspects. In our case, what we found that the most significant dimension, so subscore of the Hamilton Depression Rating Scale, was the cognitive disturbance one, where this factor, I mean the score at this specific factor at the baseline, so before the treatment, the score at this factor was predictive of how much that person will improve in terms of a total Hamilton score after treatment. Okay, so cognitive disturbance in our sample of 171 patients was the most important to predict the response to TDCS in depression. So cognition seems to be very important in the effect of TDCS, also in psychiatric and depressed, in particular, patients. Of course, many researchers have studied this this effect of TDCS on cognition. And what we know is, this is a very early study of Pasquale Leone in Harvard on healthy subjects, which shows that the TDCS enhances working memory of healthy subjects. Study from our group in Naples showed that also in depressed patients with TDCS, it is possible to obtain improvement, statistically significant improvement in a very important cognitive function, which is the sustained attention, which is the everyday attention, sustained selective attention. Is the concentration, it is the ability to give attention to what we are doing at that moment. And as we can say, our depressed patients improved with TDCS. In terms of correct response, sorry for the Italian, correct response, error, and omissions at this test, which is called test for attentional performance. So, what we can ask ourselves is which specific effect of TDCS drives the improvement of the depression as a whole? Are these the effect on mood, on cognition, on emotion recognition, on cognitive control, or sleep, or appetite and weight? As you see, these are the most important dimension of depression. In my experience and from what I studied in literature, it seems to me that what really changes, what really drives the improvement is the improvement of cognitive processes, important for mood regulation. You know, cognition and mood are, of course, interconnected. Speaking about interconnections, we have also to say that, of course, TDCS interacts with other intervention, interacts with drugs, interact with psychotherapy, because all these interventions can change our brains. So I'm also psychotherapist, so I'm very interested in the interaction between psychotherapy, especially cognitive behavioral therapy, and TDCS, and I'm not the only one, because there are studies that say that non-invasive brain stimulation and psychotherapy are a perfect match. But why this? Because first of all, they are important commonalities as the intermittent administrations with one or more sessions per week, biological behavioral effects outlasting the single session and the treatment course, and the possible combinations are one after the other, simultaneously, or with different frequency. For example, daily TDCS and weekly CBT. Among the brain stimulation techniques, TDCS is particularly indicated for the combination with psychotherapy because it is cheap and above all is easy to administer, is non-invasive, is space saving. So the client can wear his electrodes while he's doing his CBT session. But what is the rationale for combining these two interventions? First of all, TDCS boosts cognitive training on healthy subjects and patients with cognitive impairment. So there is a synergy between a training, a kind of training, which is the cognitive training, and TDCS. And why shouldn't be the same for psychotherapy and TDCS? In healthy subject, TDCS boosts cognitive control over emotion, particularly negative emotions. In depressed subject, TDCS abolishes the interference of emotional stimuli on working memory, and the cognitive control training boosts the antidepressant effect of TDCS. So, as you say, there is a two-way influence between the two interventions. Moreover, the response to CBT in depressed patients is correlated to a prefrontal cortex activation, just the same thing that TDCS does, and the normalization of functional cognitivity between upper cortical structures and limbic deep areas. More, CBT reduces right dorsolateral prefrontal reactivity to negative stimuli that was TDCS does with the cathode over the right dorsolateral prefrontal cortex. Then there is also a molecular aspect. In preclinical model, TDCS-induced LTP, D-cycloserine studies showed that CBT action is mediated by NMDA receptors that are necessary for the synaptic plasticity. Okay, this is the very first paper on the combination between psychotherapy and TDCS. It was a letter to the editor that I wrote with my colleagues, including Alberto Priori. And it was a case report about a woman with very severe depression that was ill, that had been ill from 20 years, that had at least 10 major depressive episodes. And the current episode was lasting from 2 years at that time. As you see, the total, the baseline, the pre-treatment Hamilton Depression Rating Scale score was quite high, 27, and it dropped after the first week of TDCS to 6, and then at the end of the treatment was 10. So a very, very good response. But in the couple of weeks that followed without treatment, the patient was worsening. So we thought of combining a new course of 10 daily sessions of TDCS to combine it with CBT. And this led to a long-lasting improvement, as you say, also even after the end of the 30 weeks psychotherapy. And at 1 year from the start of the study, the patient was still well. So this is the very first example of a combination of TDCS and psychotherapy, in particular cognitive behavioral therapy. But since then, many studies have been, actually not so many, but some studies have been done on this topic. And there is, I think, still in progress, this study that whose protocol was published in 2017, but I think it was stopped for COVID. This study is a very big study with the 4 centers, 192 patients, with the 3 experimental groups, combining group cognitive behavioral therapy with the TDCS, active, real TDCS, and sham TDCS. So the patients are supposed to be wearing their electrodes during the sessions, the 100-minute sessions, and the half of them was with the active TDCS and half with sham TDCS. The TDCS starts after 20 minutes. The psychotherapy session start and lasts for 30 minutes. Okay, we are all very curious, and we're looking forward to seeing the results of this study. So what could be the outlook? What could be the future of this combination? Maybe TDCS could be used as a CBT enhancer, for example, like D-cycloserine. I don't know if you know these few studies of very interesting of D-cycloserine and CBT, but maybe now we have no time for this. Or, for example, as a maintenance treatment for TDCS effects, is it true? It is true that TDCS is easy to administer, but it is also true that coming to the hospital or coming to the clinic every day for stimulation is time expensive. So CBT with the weekly sessions could be used to maintain the TDCS when this technique makes a good result. There are also neural predictors of the treatment response to the combination of TDCS and CBT. As you see in the square, in red square, if a working memory task activate very much the left prefrontal cortex, then the response to the combination of TDCS and CBT is better. So as you see, this is a very, very, very important journal from the Nature group, and this is a very interesting data. Of course, there is also the combination of TDCS and drugs. This is a very, very little explored field. We are trying now to analyze the data that I showed you before about the clinical predictors. We are trying to study and to analyze those data to explore if a special combination of a specific combination of drugs will give TDCS a bigger improvement, bigger results, better results. In this study, of course, there are few studies like this. Andre Brunoni showed that there are drugs that augment the TDCS effect, like the serotonergic agents, but there are others that can reduce the TDCS effect, and this is the case of the antipsychotic agents, for example, and the anti-epileptic agents. So what are the open questions in the use of TDCS in depression? First, the dosing. We don't know exactly how big should be the electrodes, how long should the session last, what should be the current intensity, of course in milliamp, but 1 milliamp, 2 milliamp, 3 milliamp. The spacing of sessions, how many sessions in a week, how many sessions per day, the montage, of course, and how to engage, how to find and study the target that we are searching for with TDCS. And we have also questions about how to measure the outcomes and which could be the biomarkers of the effect of TDCS. For example, not basing only on clinical scales, but to find a biomarker, for example, a growth factor like BDNF, BDNF, and its expression could be of help in understanding the effect of TDCS in depressed persons. The same is for neuropsychological examination of patients. Then we have the big problem of inter-individual variability. We know that different persons respond in a different way to the TDCS, and also the same person responds in different ways in different moments. And this is due to the so-called state-dependent effect of TDCS. That means that the effect is related to what the brain, what that person is doing while he is being stimulated. Okay, and as you can see here, the distribution of the electricity, where you say more red, there is more electricity, changes depending of the shape and the position of the electrodes, and can be, of course, important to determine the clinical effect. More, there is also an important role, as Roberta said, of white matter, which is still a big question mark for us. We don't really know, we don't exactly know which is the role of white matter in this story, because we have also thought about gray matter, and neurons. And to summarize, we have to optimize all these parameters of TDCS to use it for depression. So dosing, individual variability, electrode montage, the combination with medication and task in our case is, of course, CBT, for example, and the predictors of response. Some slides about schizophrenia. There is also for schizophrenia a rationale for using TDCS. And the first one, just like depression, comes from neuroimaging studies, where we know that the hallucination, auditory hallucinations, are correlated to a hyperfunction of the temporoparietal junction, and so the therapy, the intervention with TDCS on auditory hallucination entails reduction of function and inhibition of that area, left temporoparietal junction. Just as in depression, the dorsolateral prefrontal cortex of schizophrenic patients is hypoactive, especially at the left side, and this should account for negative symptoms of negative and cognitive symptoms of schizophrenia. So this is the rationale. And so the bifrontal TDCS with the anode of the left over the left prefrontal region and the cathode over the right prefrontal region can be used to decrease negative symptoms. So the first montage that you see above is for auditory hallucination. This one is for negative symptoms, should be for, it's the rationale. And the bifrontal, of course, is just like we saw before, for attention and working memory, is supposed to improve cognitive symptoms in schizophrenia that are very, very important. According to recent studies, maybe working memory problems, cognitive problems are the pivotal problems, issues of schizophrenic patients in terms of functioning, everyday functioning, and in terms of prognosis. We know now that prognosis of schizophrenic patients is more dependent from cognitive symptoms than from, for example, hallucination or delusions. So these are the studies, always from the review we saw before regarding schizophrenia. always RCT, always with sham control. The results say that 10 or more twice daily. This is very important. That the sessions, differently from depression, the sessions for schizophrenia has to be twice daily, 3 hours apart, 10 or more twice daily, 3 hours apart, left prefrontal anodal, left temporoparietal cathodal, improve auditory verbal hallucination, that's for sure. Then another result is that, result of the review is that the tdcs all montage pooled significantly improve hallucinations and PANS, which is the positive and negative symptom scale of schizophrenia, to a moderate degree, but with high heterogeneity. Again, these studies are very, very heterogeneous, like the ones, maybe these ones more than the ones for depression. And the studies with greater severity of negative symptoms at baseline seem to show better results. This is very, very interesting. And also, it is not reported here, patients' age was correlated to a better response. So the older were the patients, the best was the response, which is counterintuitive. And finally, TDCS induced a change in functional cognitivity between disease-related cortices was detected. So these are a bit more in detail, a couple of trials. This is a trial from France, from our friends, Jérôme Brunelin and Marie Mondino, and they obtain a significant decrease of resistant auditory verbal hallucination in 31% of their patients. And this lasted for 3 months. Another study showed a significant reduction of PANS score, but predominantly negative symptoms. And in this case, the montage was different because there was not the inhibition of temporoparietal cortex. So the study was targeted to the negative symptoms and was positive. Also, positive results have been found with bifrontal TDCS in case studies of resistant negative and catatonic symptoms. And what is most important, in my view, is that bifrontal TDCS improves working memory in schizophrenic patients. There are also studies with the transcranial random noise stimulation, but this is still in its infancy. So I was saying about the working memory improvement. This is very, very important. Combining TDCS with working memory training improved a lot, as you say, very much, the working memory of patients. Both if we combine TDCS with training, and if we don't combine TDCS with training. And I think this is the most promising result regarding TDCS in schizophrenia. Thank you for your attention.
Thank you very much, Giordano. Thank you, Professor Ferrucci and Professor D'Urso, for your general information and for your specific information, for all the expertise that you have in this field. I want to remind to everyone that we have question and answers. We already received many questions. Poate vorbesc în română. Mulțumim pentru toate întrebările dumneavoastră. Mulțumim celor doi speaker pentru intervenția lor, pentru informațiile generale pe care ni le-au dat și de asemenea pentru informațiile specifice pe care ni le-au dat. Vă reamintesc că e posibil să ne puneți întrebările dumneavoastră, să ni le puneți în zona întrebări și răspunsuri pe care o aveți în josul paginii. O să iau câteva dintre întrebările pe care mi le-ați adresat, pentru că sunt foarte multe și să nu ne lungim foarte mult. La restul vă vom răspunde în privat, pe mail sau cum doriți dumneavoastră. O să vă rog să ne scrieți pe mail osăcuiu@medaima.ro, unde putem să vă dăm toate informațiile de care aveți nevoie. Vă reamintesc și că webinarul a fost înregistrat. Vi-l putem trimite tot așa solicitându-l pe mail fiecare dintre noastre și vreau să vă invit ca la sfârșitul acestui webinar, înainte să închideți linkul de acces, se va încărca un link cu un feedback chestionar, deci un chestionar de feedback pe care vă invit și ne-am bucurat să-l avem din partea noastră ca să știm dacă informațiile v-au fost utile, vă ajută, ce putem să îmbunătățim, ce informații putem să vă dăm și așa mai departe. Vă mulțumim pentru asta. Bun, să vedem câteva. I will put some questions, Roberta and Giordano. I will ask you some things, and then we can answer to all, because we have a lot of questions. We don't have time to answer to everyone, but we will answer after by mail to each of the person that is interested to know more, and maybe if it's possible also one by one if they have some specific things that want to ask you directly. Okay. So one of the question is, which are the indication for whom the HDC Stim device is CE approved? I don't know if Roberta wants to answer or Giordano, or I can answer as you want.
Please, please.
Okay, so I will answer from Neuronica side in this moment. tdcs HDC Stim, it's CE mark approved as medical device from 2009 for 3 indications: depression, chronic pain, and post-stroke rehabilitation. Professor Roberta Ferrucci is one of the first professionals that used HDC Stim in many fields, as she presented already the general introduction. Maybe Roberta, if you want to add some more to this.
Sorry, Mirela, I don't. Could you repeat the question, please?
Yeah, the indication. I spoke about the indication for whom the HDC Stim is approved, CE mark approved.
Okay, is approved for pain disease, for rehabilitation, for stroke, and for depression.
Yeah.
But there are a lot of clinical trial, labeled clinical trial for dementia, for Parkinson's disease, and the other movement disorder.
Okay, perfect. Thank you very much, Roberta. Another question is, let me see. I understand that it depends on the shape and the place where the electrodes are applied. If they are placed incorrectly, there are a worsening of system or no positive response for Giordano.
No, in my experience, first of all, we have to say that generally speaking, TDCS is not so has not a very high spatial resolution. So even if we put the electrodes 1 centimeter forward or 1 centimeter backwards, it doesn't change very much. So this is not an issue. So in my experience, when the position is not perfect, it is not a problem. And I guess that if the position is incorrect, what you get is no response instead of a worsening of the condition. I don't know if Roberta agrees with my view.
Yes. I agree with Giordano.
Okay, thank you very much. We go to another question. Can TDCS be used as a maintenance treatment for depression if favorable results have been obtained after 15 sessions or 20 minutes each? and what time period can it be repeated, and what is the administration protocol for this situation?
So this is very, very important and interesting point. Actually, this is what we are trying to elucidate now with our trials, because we know that TDCS works on depression, but we don't know exactly how to maintain this effect. It is also sure that doing maintenance sessions is useful, but we still don't know what should be the perfect frequency of these maintaining sessions. In my view, and from a clinical point of view, it depends very much from the patient, because just like for other kind of interventions, like for example drugs, the dosage of maintenance therapy is always different. It's different from each patient. It depends on how he responded, how quick was his response. So I would say that from a minimum of 1 session every 2 weeks to a maximum of 3 sessions per week should be the range for maintenance TDCS. Of course, there are also studies with 1 monthly session for maintenance, but I'm not sure that it can maintain the biological effect.
Okay. Thank you very much for this answer. I will go with another question. To some points you partly respond in the presentation, but maybe we can be more directly on this point. What are the main classes of drugs that influence current intensity and the TDCS efficacy?
Well, current intensity should not change depending on the drug you use. Even if this is not always true, but let's skip this. What is important as a general rule is that antidepressants go in the same direction, of TDCS. So coupling antidepressants and TDCS is a good choice. On the contrary, antipsychotics and antiepileptics seem to reduce the neurobiological and neurophysiological effect of TDCS. But this doesn't mean that the effect is null. The effect of TDCS is null. This can mean that the effect will be more slow to appear. No? Especially for antiepileptics, this has been seen that the effect is slower, but still present when you use TDCS in combination with these drugs.
Okay, perfect. Thank you very much. Another question. There is a guide for montage of electrodes for depression.
A guide.
A guide. How to
Go ahead.
How to place the electrodes for the depression. Guide for how to
you
place
need a marker and a meter.
A marker and meter, but of course maybe there is with the specific position how to measure, how to place the electrodes for the depression, like a guide.
Actually, like a guide, you can use the system for the 10-20 system for EEG, and the place where you have to put the anode for depression, so the positive electrode, is the F3 of the 10-20 EEG system, and the place to put the cathode is generally, but this changes from study to study, is generally F4, so the symmetrical point on the right frontal lobe. And you can find these points in several ways. There are labeled device to find these points.
Okay. Thank you very much. Another question, let's say more general. What are the contraindications identified in the studies? Giordano, okay. If you can answer, or Roberta.
Contraindication are the pacemaker for a cardiac problem, or pregnant, or there are not a lot contraindication because the technique is really safe, and also epilepsy, but there are few studies on women pregnancy or in epilepsy, so it's very safe technique.
Okay, thank you, Roberta. Giordano, you want to add something, or?
No, actually, epilepsy was considered at the beginning of the story was considered a contraindication, but then we have seen also studies using cathodial TDCS to cure epilepsy. So this is not so stringent contraindication. Of course, we have to pay attention to epileptic patients, especially if you use a nodal, so an excitatory stimulation. But for example, in cases of cortical epilepsy due to malformations, cathodial TDCS has shown to be efficacious and effective in reducing epilepsy. So, and also for what concerns pregnancy, there are patients, pregnant patients, who don't want to take drugs and are severely ill. In that case, if you make them sign informed consent, you can use safely TDCS, because we don't have any report of problems to the fetus or the pregnancy due to TDCS. But of course, we for a new kind of therapy, we are forced to be very cautious with this population. But this doesn't mean that you cannot use in pregnant women.
Thank you very much. You anticipate my my next question, that was for that if we can apply TDCS treatment during pregnancy or lactation. So you anticipate my question. So the same for lactation.
No problem at all for lactation.
Thank you very much. Okay. I will put one more question, and I will want to thank you again to all our more than 110 participants to this seminar, to this web seminar. Thank you very much to each of you that you participate. You were with us. Hopefully, all the information was useful for you. And if you want to put some more questions, just do it on the dedicated place in on the webinar, or you can write to oscuiu@medanima.ro. So last question, and after this we close, because it's 1.5 hour time. So I want to thank you all. The last question before to close, and before to put the question, I want to remember to all of you, before to close the seminar, to go to the link and to fulfill to complete the feedback questionnaire. Thank you very much. You will help us to understand how was the information that we give to us, and how we can help you with more information and with more details. Thank you to everyone. So the last question is, in patient whose dominant cerebral hemisphere is the right one, is the location of the electrodes reversed?
Good question. For psychiatric disease or for depression, I think there is no problem. It's the same montage. We use the same montage. For other kind of patient or for cognitive process of function, yes, this is a problem because we use the different montage.
Okay. Giordano, you want to add some more?
No, in my field of psychiatry, I usually don't care about the dexterity or of the patients, and I don't have any data from literature that shows that you can take this in consideration, in account for the treatment of depression. Actually, it would be it is an interesting question if we refer to auditory hallucination, because we know that language is lateralized, but I think that there is no difference.
Perfect. Okay. Thank you very much, Profesor Giordano D'Urso. Thank you very much, Roberta Ferrucci. Vă mulțumim pentru participare celor peste 110 participanți care au fost astăzi alături de noi în acest webinar. Sperăm că toate informațiile v-au fost utile, atât cele generale cât și cele specifice pe care vi le-au dat cei doi speakeri ai noștri. Vă reamintim că acest webinar a fost înregistrat și puteți să solicitați înregistrarea la mailul care este afișat momentan osăcuiu@medanima.ro. De asemenea, am primit foarte multe întrebări din partea noastră și ne bucurăm pentru că înseamnă că v-a strânit interesul să încercați această tehnică și poate să o folosiți spre beneficiul pacienților noastre, evident. Răspunsul la toate întrebările vi le vom da în scris. O să vă rog să lăsați, să trimiteți, noi le avem, dar să avem toate datele noastre de contact, să ni le scrieți pe aceeași adresă de mail, osăcuiu@medanima.ro. Vă mulțumim încă o dată pentru participare, mulțumim organizatorului domnul Ovidiu Săcuiu, Medanima Clinic și Medanima Tech, Ramona Oprișan pentru toată activitatea ei ca să decurgă totul bine, mulțumim translatorilor și sigur că fără dumneavoastră participanții de astăzi nu ar fi fost posibil pentru că informațiile să ajungă la dumneavoastră și mai apoi tratamentul la pacienții noastre. O să vă ținem la curent pentru viitoarele sesiuni informative pe care le vom avea și sigur în momentul în care vom organiza un seminar live într-o locație pe care o vom stabili, vă vom ține la curent, scrieți-ne și noi cu mare drag suntem alături de dumneavoastră. O zi minunată vă doresc, mulțumim și la revedere!